Good afternoon and welcome to Health and Human Service Committee. It's Wednesday, May 21st, 1 o'clock. We call the meeting to order. We do have a few changes to the agenda. We are going to move the county administrator's report to the end of the meeting. Do we have anybody here for public comment? No public comment. Can we do the minutes approval for the April 16th meeting? Shauna moves, Randy seconds. All in favor? All right. Appointments, we do have one appointment. Community Mental Health Service Board, Mental Health Subcommittee, Cindy Friedmutter, community member, term expires December 31st, 2028. I'm going to move her. Shauna moves, Randy seconds. All in favor? All right. The chair's report. We do have a guest today. I want to invite Frank Krupa up. Marty, are you joining him? He is. All right. Frank Krupa and Marty Stallone from Cayuga Health Systems. An update on the Intensive Crisis Stabilization Center. Welcome, gentlemen.
Thank you very much.
Frank, I feel like I've seen you here before.
My part, thank you for having us. Marty Stallone, the CEO of Centralis Health, which now includes everything in Cayuga Health System and Arnett Health. So a little bit of an expanded role, but I'm here to talk about the Intensive Crisis Stabilization Center concept that we committed. I'm going to have the easiest, shortest presentation ever because I'm going to hand it over to Frank to talk about all the details, and we appreciate having him on our team deeply for the record. My role, what I wanted to say is that the need for and our commitment to an intensive crisis stabilization has not changed, and we're working vigilantly through the many barriers, some of which are new given the organizations who were previously involved in some of the mental health related enterprises that we have taken responsibility for, many of which you're responsible. But from our board's perspective, from our awareness of the need, it remains. And so we're still committed to doing that. We've got great people working on it. And I'm here to support Frank, who's been much more tactically involved and taking us through the details. So I'm going to pass this mobile microphone to my left.
I'll take both. Thanks, Dr. Stallone. And it's great to see everyone again, be back in this forum. I think the good news is we are on a path to achieving what we had all set out to do, which was create a withdrawal and stabilization facility coupled with intensive crisis stabilization at 2353 North Triphammer Road, so the building that we're all familiar with. Probably the biggest achievement we've had was the end of April. We gained control of the building. So we have a lease in place now. So we are managing. You may have noticed the lawn got mowed yesterday. So first step, we're still trying to get the power turned on, but all of that is in the works now. And so that was a really first big step, was we needed to have control of the facility, which we now do. We have put together a plan with target dates for the beginning of December for the withdrawal and stabilization component of the project, which would be the the entry into care that would allow for medically assisted detox to occur in the 20 beds that were assigned for that. And then the other 20 beds were for the stabilization. So we expect to have all of that at least operational by the beginning of December. Obviously, we're not going to have every bed filled at that point, but that is our target. The intensive crisis stabilization, we're still targeting the first quarter of 2026. There is some construction that needs to happen at the building that will be done thanks to an allocation from the legislature to support that. We have been in talks with the architects, so we have drawings in hand. We are seeking review from OASIS and OMH for approval on those with hope that those things will go out to bid mid to late summer. So we're still on track for those things. There's several key factors, obviously, that are going to impact this that will all need to align perfectly for us to hit those dates. So probably the biggest challenge is going to be around staffing. Yesterday we posted for the program director for the detox and stabilization component of it. So we are actively looking for the leader that will run the program there. And once we have that person on board, they will be helping us build the team from there forward. One of the strengths that Cuyahoga Health System brings to the table is the ability for the HR and talent acquisition team to help us navigate those. So we've been having internal meetings with them, setting a plan together to prepare for the many staff that we're going to need to bring on board in order to get the project operational. Another key factors around licensure and credentialing. So we have to get our licensure paperwork into OASIS for their approval. We're actively working on that, hoping that by the end of this month, that paperwork will be submitted. That will likely take them a few months to approve. And then once that's completed, we then have to get credentialed in order to bill. So that will also take a couple of months' time. So we're really, putting a plan together that we've got to hit all of these benchmarks in order to achieve our target of that early December opening of the facility. So that's essentially where we are at the moment. I think it is good news. I'm fairly confident that we're in a good place today to be able to hit the targets that we've set. And as we continue down the path, we'll certainly continue to provide any updates that you might want about where we are or where we might need some help or support to get there. But I think so far it's really all positive news on this front. And having been in the building recently, it just adds motivation. It is a beautiful facility that was designed for this purpose, and we really need to get it open to serve the people that need these services in our community. So that's what I had. I'm happy to answer any questions you might have.
Sean?
Yeah, I have a few questions. The first one is, will Dr. Mead still be the one that's in charge of the center?
Dr. Mead is going to be a part of the process.
Okay.
He has other significant responsibilities with the health system.
Okay.
We have recruited another addiction medicine physician to come on board in the summertime.
Okay.
That will be helping us to both build and support the operations of the program.
Okay, great. And then my other question doesn't necessarily have to do with this, but it has to do with, I will always call it CMC, and I'm sorry for that. Okay. I have received concerns from constituents about there being announced that there are STEMI diversions at the hospital, and I wanted to see if you could talk a little bit to that, because I feel like there's some unease in our community about what happens if they're having cardiac issues and where they would go and what the process is.
So that has to do with upgrading and construction having to do with our cath labs. The cath labs are not only used for STEMIs, and for reference, that's ST elevation, MIs being heart attacks. So normally there are 2 rooms, but those rooms are also used for other interventional procedures, hence there's 2. There's always the possibility of diversion happening if staff were to get sick or if there was some sort of a facility power issue. So it's not uncommon that we go on diversion, but it's happened more because one of the 2 labs is down for renovation, constructions, upgrades because of the end-of-life nature of some of the equipment. So there have been more diversions. When that happens, the regional EMS is notified. Other hospitals step up. The State Department of Health is notified. It's a fairly defined process. It's not something we like. It's something we endure in the interest of keeping up with our facility needs. So I can say that your concerns are based on true stories, and we're, I think, a month away from the construction being completed. And it's something that our operations and facilities teams tries to minimize, but it does happen from time to time. I would point out that our STEMI program is relatively new in the history of the health system. Many communities our size are not approved to do STEMIs. It's a gift to the community. It has to do with time to restoring blood flow to muscle, which is critical in outcomes. So I will say, historically, we have remarkably little downtime that I think people are noticing when it's happening. But in fact, we're blessed to have this capability, so I just want to keep everything in context with expectations understood and things kept in proportion, that many communities don't have this in the first place. So I think we're lucky to have it, and we look forward to it being more reliably up in the imminent future.
Okay, thank you.
Any other questions? Randy?
Thank you for coming, and that's good news, Frank and Marty. It's exciting I think, for Tompkins County that this is moving forward. Are there any concerns with how you're going to fund this over time? Is there a lot of Medicaid patients who will be coming through here, or what are your thoughts on long-term being able for it to be sustainable?
Yeah, well, I would suggest that there's always concern in healthcare about sustainability. I don't think that there ever isn't. For the detox and stabilization component of this, there is $600,000 annually of state aid reimbursement that is assigned to the program. So that is what's called deficit funding. So it's provided assuming you will have at least a deficit of $600,000 in your operations. So we do have some support there. Billing mix is always a component of this, whether it be Medicaid, private insurance, or other, to try to build a sustainable program. The intensive crisis stabilization piece of it, quite honestly, everywhere else that it started in New York received funding along with that program, but Cuyahoga Health System made the commitment to do this without that funding. And the reason that we were able to, the health system, before I was even there, was able to make those commitments was the long-term vision that by getting people to the right place for the right care, will help save costs in other places in the health system, namely the emergency department, which we all recognize is not the best place of care for someone that's in a crisis for a mental health or substance use. And when you bring those crises in the ED, then it makes it more difficult for everyone else that's trying to receive services in the ED. So there is that vision that it's bigger than just the program itself. It's really looking at the scope of the entire health system and what the impacts would be by having these correct services in the right place for the right people.
Great. Thanks for that. What are your, I assume you're going to be working with law enforcement and other people on to how to transfer people there, and how does that process begin, and what are your thoughts on that?
Yeah, a part of the licensing process is getting MOUs in place, right? Because the idea of the facility is we want to have a smooth transition into the care there, and we also want to have a smooth transition out of the care there. So we have to work with all of our community partners, including our first responders that might be bringing them to the facility. In fact, the licensure for the Intensive Crisis Stabilization Center requires a separate entrance for law enforcement and EMS. So the building is designed so there's a separate place so folks can be brought in that doesn't unduly embarrass or expose them to others that might be in the building, while at the same time creating a safe environment for law enforcement and EMS to bring folks in. So it is all part of the design, and the licensure, as I said, does require us to work with our partners, including first responders, and getting MOUs in place on how things will work to interact successfully with the facility.
If I could add, all the parts of the health system need to work together here. So the emergency room, law enforcement, EMS to ED for medical stabilization, to crisis center for mental health, or to stabilization or detox for substance use disorder. That's one pathway that needs to get created and smoothed and perfected. Also, PCP office, primary care provider office, to rehabilitation facility or crisis stabilization center is another pathway, as are self-referrals and open access, which was another theme. So one of the visions I just wanted to remind everyone is that having this capability within one health system allows for all of those patient pathways to be perfected over time.
A follow-up to that, whenever we talk about patient pathways, I mean, obviously you're going to render the care of detox and then treatment and try and give people the tools so that they can live a healthier life. My question is, whenever, after they've gone through the program, is a big part of helping them move forward, the discharge planning, making sure that they actually have the supports once they get out. Would that be done through your program, or would it be referrals or working with county services, or what does that look like?
It's all of that, Shauna, but it is part of the licensing to have pathway relationships to get people to the next level of care. It is a short-term facility, so the maximum length would be 28 days, right, for someone to be there. So as soon as they walk in the door, we should be planning for their discharge to find out where the appropriate place for them to be, whether it be a residential placement, an outpatient placement, or referrals to other types of organizations. But yeah, absolutely, it would be part of the programming.
Okay.
Oh, and of course, CARS is under, the Cuyahoga Health System umbrella, so we have those resources within our own system as well. Obviously, the client has choice and will work to do that, but knowing that we have the ability within our own organization to build strong, warm, even hot handoffs to those other programmings, we hope will be an added benefit to the program.
Great. Thank you.
Yeah, just a comment. I have a friend who's a vet, and he was trying to get into a facility, for detoxing and whatnot, and he ended up in Bath. And it's a 90-day program, and it's 160 beds. I was surprised that there's that many beds there, so that would be another resource, and it's about 2/3 full. So I just wanted to share that information.
Sure, and CARS has broken ground on the 25-bed women's facility in Trumansburg next to the 60-bed men's facility. So we will have 85 residential beds in CARS as well, hopefully by mid-2026 too, which will be an added resource in the community, so folks wouldn't have to travel so far necessarily to access them.
I visited the Bath facility. I mean, they have a bowling alley, a library, and a lot of really nice, they have a baseball field, and there's all fishing. So it's, he said it's kind of like a vacation, so hopefully it works. So.
Well, as we continue to support and find ways to create opportunities for folks who are struggling the most in our community have better outcomes, this is really exciting that we're at this place now. It just seemed like it never was going to happen. So this is really exciting. Thank you for coming in today. I do have one question. I know that when I had visited before, and it was when it first opened, it never really opened, but when it first opened, they were explaining that there would be no real security at the location. And it was a little concerning given, the struggles that people would be having at that time. And a lot of us thought that it would be one of the deterrents for nurses to want to work there. Do you plan on having any sort of security there?
So the intensive crisis stabilization regulations have stronger security requirements than the detox and stabilization did, which is what was previously only going to be in that building.
Right.
So by adding the intensive crisis stabilization center component, it's going to allow us to look at and develop further stronger security for the building.
That's good.
That's really good. Thank you. Well, thank you for taking time out of your busy schedules to come in and share and update the community. This is exciting, and anything you need, we're here if we can support. So we look forward to having you come back maybe this fall and let us know how things are going.
Absolutely.
Thank you.
Thank you.
Great.
Thank you.
As I said earlier, we are going to push the county administrator's report to the end of the meeting. Now we're going to go right into resolutions. And the first one we have is from the Department of Social Services. I see Dina is here. Budget adjustment, Department of Social Services, year-end 2024, transfer ID 13249. Do I have a mover? Shauna, do I have a seconder? Randy. Dina, would you like to share?
This is just a standard kind of transfer we do to balance out budget adjustments from 2024. So there's nothing exciting about it.
Any questions? No?
Yeah,
All right.
question.
Well, Randy has a question.
Yeah, so there's a difference in you receive more income than you expected. So does that go into a specific account within Social Services for the continued program, or?
Yeah, we do. So I don't know about the specific additional income, but we do sometimes, because the state can be delayed in terms of getting us reimbursements on things and that sort of thing. So I do believe we have a couple of accounts set up with finance where we put that kind of income into. Yes.
Okay, thank you.
All right, any other questions? Are we ready to vote? All those in favor? All right. Dina, would you like to give any updates or share on anything going on with the Department of Social Services while you're here?
Sure. So just update on the shelter. Currently, we have 95 people in shelter. 82 of those are adults and 13 are children. And so the ones with children include, we have 10 families. In our eligibility division, we just recently had audits for TANF, that's Temporary Assistance to Needy Families, and to SNAP, which is the Supplemental Nutrition Assistance Program. And we did very well in both of those. In our Adult Protective Long-Term Care division, there's been, and maybe some of you guys have heard in news and stuff, there's been changes to what's called the Fiscal Intermediary Services Program. So this is services that, like in-home services, that we pay the intermediary and then they pay the person. And so the state's gone through a lot of changes. We've got everybody enrolled so that all our in-home service providers are receiving their income. And so, and not every jurisdiction can say that. So we're very happy with that. In our Children's Services Division, we've had a number of staff go through motivational interviewing training. So motivational interviewing is a strong evidence-based practice for helping people make behavioral changes. So we're getting a lot of staff trained on that. We have a lot of new staff come in. And those new staff will also be going to the foundation's training held in Albany for new child welfare workers. So folks are pretty busy. Thank you. Any questions?
Shauna?
Hi, Dina. Can you tell me who performed the audits and were there any findings?
I don't have details as to whether there's findings. I presume that the audits were by the state, the state representatives for the federal government. But I can get you more detail on that.
Okay, that'd be great. Thank you.
Any other questions for Dina? Randy?
In-home care, how many people are enrolled in that program?
So I don't have that detail either. I don't keep track of that. Next time I'll know. I should come with more information for everyone.
That's okay. It's a good program, so it's good. Thanks.
Any other questions? No? All right, Dina, thank you.
Hey.
All right, Office for the Aging, Lisa, and she's here with us.
Hi.
We have a resolution, budget adjustment, Department of Social Service, Department of Social Services, DSS and County Office for the Aging, COFA, transfer of full-time equivalent, FTE, and associated budget from DSS to COFA ID 13274. Lisa, would you like to share? Oh, we got to move it, I'm sorry.
I'll move.
Randy seconds, thank you. Okay, Lisa,
Sure.
got ahead of myself.
That's okay. Thank you. So this historically is a program that COFA does. It's our expanded in-home services for the elderly program. And we have historically had a memorandum of understanding with DSS to provide the case management and a case aid for this. So every year in our budget, you see an interdepartmental budget transfer. So this is just kind of doing away with all that because it doesn't really make that much sense that they're over there and not with us. I think what happened years ago when COFA was in the basement of the old jail, there was no space for the case managers there. And it just kind of was one of those things that we just kept doing. But it has been difficult since we hire the home health aides directly now. We have a couple. And just for continuity of their care, it's better to have them be in our office, be able to communicate with the aides directly. And also, we're on two different systems. We're on the county system, DSS is on the state system. So there's a lot of bugs that happen between, encryption and just stuff like that. So it's really helpful. We'll get rid of the transferring of funds between county departments, and it's all of our budget that paid them anyways. So we're just bringing that back into our budget and having it all align.
Any questions for Lisa? Randy?
Yes, Lisa, so they reside in the DSS building now?
Currently, yeah.
And they'll move to your facility?
Yes.
Where those numbers submitted to Cole?
Yes.
Okay.
And that's another kind of reason that I thought the timing was right, because, just thinking about our space program that we've been looking at, I added them in there for that. And I'm like, why don't we just have them with us now? And it just makes good sense, so.
Great. Thank you.
Mm-hmm.
Any other questions? Ready to take a vote? All those in favor? All right. Lisa, do you want to share anything for the Office of the Agent?
Don't really have a update right now. We're going into farmers market coupon season, which is great that we are going to be getting them this year. We heard that we're actually getting more. I was a little nervous that that program might be one of the ones that were being cut, but we will be getting those. It usually starts June, July-ish. And our 50th anniversary celebration will be happening this summer. We're bringing back our Senior Living Expo. That will happen in July. I'll probably have more details next month, but that's about it.
Cool. Any questions for Lisa? Thank you.
Thank you.
All right, we're going to move over to Whole Health Department. We have two resolutions and a report. Let's get the resolutions out of the way, and then we'll go into the report. Authorization to accept funds and complete budget adjustment, personnel recovery-oriented services, Whole Health Department ID 13311. Do we have a mover? Randy moves, Shauna seconds.
Okay, this is state funding that was meant to supplement this PROS program. And so we were able to be pretty flexible with how we wanted to spend it. And so we essentially have put in there the amount that the state will one time send us and all the sort of program enhancements that we'll do with purchases, provide some trainings. There's a number of things under supplies and equipment that we need. So we're trying to enhance the space. As you know, the PROS program is a place that a client can stay in all day. So those rooms being warmer, more welcoming, having more things for the groups. So it's mostly those types of expenses, and this is just a breakdown of that.
Thank you. Questions? Shauna?
Can you tell us what professional service fees are?
Let's see. So it was a little bit up in the air. We were still deciding between a couple of things, and I can get the specifics. So we've had a yoga instructor this year come in, and we've done that through some contracts. So we are trying to bring in some skills that we don't necessarily always have. And we're evaluating whether or not to try to push those forward past this one-time funding and try to find it within the budget going forward. So it is those types of things.
Okay, cool. Thank you.
Any other questions? Randy?
On the Community Mental Health Service Board, they gave, I've forgotten the lady's name who's in charge of the PROS program.
Heather Sanford. Yeah.
And gave a good presentation on this program, and I thought had good success of people becoming employed after going through the program. Could you elaborate on that a little bit for the rest of the group, or should we have her come later?
Well, it would be good to highlight PROS all on their own at some point for this board. But yeah, I mean, so the state has certainly put a lot of energy and money into the job portion of PROS. They gave us money last year for us to further develop that. We were able to boost the pay for our staff member who does that as well. And so we put a lot of time and energy into that. But you're right, so that's integrated into the classroom structure that they have. So if you're coming for classes and you become interested in wanting to find a job, that service professional is right there to help you go find it. And he's able to do things in the community or obviously in the classrooms and even go to the site, right, to help them fully integrate into a new job. So I would love to let them come and highlight themselves though, if possible at some point.
Yeah, I think that they shared that 10 to 12 people actually became employed.
Yep.
So that was good. So,
Any other questions? All right, let's take a vote. Those in favor? All right, that passes. Second resolution, budget adjustment, Whole Health Department, Public Fellow Program, ID 13289.
Okay, this is the one that I gave updates on last time. And so what we're trying to do here is essentially get us through the end of the year. This would have taken us all the way through next June if the state funding or was still in place, or the federal funding that was paying for that was still in place. Things are still in the courts, but it is currently scheduled to end at the end of May. And so if there was a court decision that continued to pay for this or fund this, then we would not need this funding. But what we've done is we've done salary projections for our entire department, and this is the portion that we are confident in that we will save due to already vacancies that won't be filled because they haven't been filled, to cover these projects to get us through the end of the year. We pulled from a couple other places where we just knew we weren't going to spend as much on printing and some professional services, but most of this is coming out of a regular pay line that we are currently saving. We have several projects that are really important to our department here that the fellows are working on. And if this were to end, we would have to either end those or we would have to have current staff pick all of that up. So this gives us a transition piece. We thought we had till June. This gets us through the end of the year. And that gives us a way to plan to bring it in-house if we need to, whatever we're going to continue. So that's the basics of it. Honestly, for good reason, all of these fellows are going to be looking to find other jobs. This was a short-term project anyway, and as they find other jobs, this money will probably reduce. But this is as if we have all four of them through the end of the year.
Well, I definitely appreciate your efforts for trying to find ways to keep this going. Is there questions from either one? Shauna?
Yeah, I mean, I guess as long as we're just allocating through the end of the year, I would probably have concerns going beyond that because I'm not necessarily sure that we should be using county tax dollars for that and for the work they're doing. I think it's nice whenever it's a gift from the federal government and it's easy to accept. I guess the other question is, could we tap Cornell on the shoulder a little bit and ask if they could provide some of the funding for this, since it's their students? And their students are getting a great internship out of this, but I question if it should be at the taxpayer's dollar.
Yeah, I mean, there has been some conversation. This was the most direct way that I could find because they're also working on pretty important projects for my department. And so I wanted to at least come with a solution there, but I do not have any other solutions past this right now.
Okay.
Randy?
Yeah, at the end of the year, it'd be great if you could come back and explain everything that they did and the outcomes and how you're going to use that information going forward.
Yes, we can definitely report on that. As part of the justification for this, we have extensive information now at this point about the fellowship, about what they're doing. So we'll be able to say what we were able to finish.
All right, any other questions? It is time to vote. All those in favor?
Mover and a seconder.
Huh? Oh, Randy moved, Shauna second. All right, that passes unanimously. Now, if you'd like to start your report, Jeremy.
All right, let me just share my screen. Okay. All right. I just want to say it's fitting that Frank is here for this, as one of those who spearheaded most of this integration, and I'm sure he could correct me on a bunch of this. I wish he were the one giving this presentation instead of me, but I will do a poor copy for today. My main purpose today in bringing you a update about integration is to start to tell you the story of where we've come so far. So we're 5 years into this, or 6 years, it feels like a lot longer than that. But COVID disrupted a good chunk right in the middle, but we are back on track, and we have really 3 or 4 good years now of really good progress. And I just want to make sure that everyone knows and can see what this collaboration is bringing to our community. So that's going to be my primary mission. And before I start, I just want to remind us why we did this and why it was important. So the goal of integration, and when I say integration, that is of the public health and mental health departments, was to provide holistic care to our community. That if you came to either of our doors, you would be able to be treated as one person, rather than having to engage in multiple systems and go through multiple doors and tell your story over and over and over and over again, and fill out different paperwork that really says the same thing. And one of the reasons I have loved working for Tompkins County is that we didn't go into this just saying we wanted to save money on a department head. That wasn't the mission we were given. The mission we were given was to provide better care for our community. And so that is the mission we've been driving from since the very beginning of this. When we make a decision about an administrative person or anything, we always ask, is this better for the community? Rather than, does this just work better for us? We've learned a lot along the way, and there may not be a perfect licensure for us to just do all of this in the same room with the same client, but what we have found is that we can shoulder the burden of the system where the client should not have to. In the past, the client would always have to shoulder the burden of all these different programs and what it takes to get into services. And you would have a mom deciding between going to a WIC appointment or going to get mental health services, and they wouldn't be able to do both, right? And so we wanted to shoulder that burden and let them feel like it's a streamlined service, that we are going to treat you as one, and here's the menu of services we have, and if you want them, we'll gladly provide them today, or we'll try to talk you into it if we really think it would be good. So we want to take on the barriers and take that off of the client. And through integration, we are seeing already that we can maximize client outcomes. If you walk through the door, and I now know I'm not just a mental health provider all on my own trying to serve you, but I can make sure that your kids are going to get early intervention services, or we're going to make sure that you have food, or we're going to get you a community health worker who can help you find housing. Like, there's a much greater outcome now when you walk through our doors than there ever has been before. And I'll try to show you the difference between what it was like before and what it is now. The last point I'd make before we move on is just, this is allowing us capacity and flexibility when our community changes. Before, it was very difficult to respond to a change. If needs changed, if all of a sudden it was all about kids, or all of a sudden it was all about adults, or COVID happens, we now have this capacity, the system that we built, where we can be flexible and we can depend on each other and get through it rather than being isolated and on our own. So with that, I'm going to go into where we started. This is, you're not meant to be able to read all those names or anything, but this is 2 very distinct organizational charts. When I first started, I would not have known, working for mental health, what anyone does at public health. There was never conversations between the two. I don't know if the department heads knew each other at that time. There was certainly no collaboration between service providers unless it was a very special case. These were 2 distinct organizations, departments with very different missions that often you found after the fact should have collaborated when they would plan for something. It turns out we all figured out the same needs, but we did 2 different plans, and now we can't work very well together. So that was where we were in 2019. 2 department heads, and then of course the organizational chart below that. Again, clients had to engage in multiple systems. Clients had to know how to navigate both of these systems. We found very quickly that if we were going to integrate, this was not going to work. This organizational structure was never going to work. We went through a period where we were identifying skills and experience that we would need. There are a number of positions that we wrote job descriptions for that were meant to be joint positions that we did not have before. And without them, we could not have done what we've done. And you'll find later, and for the most part, we didn't ask for any money for that, right? We repurposed old positions or we just restructured. But essentially what we were doing was give ourselves a jumping off point, a structure to be able to do this work that just didn't exist in these 2 silos. So we want now to tie everyone's work to the client. And I'm going to move on to this next one. This is going to look real busy. So you're not meant, again, to understand all of this. This is the new structure. And what we've done is free up a commissioner to see the entirety of the system. How do our services fit into this community? What are the community's needs? How can we meet them? And then you have 3 deputies under that commissioner who bring the voices from all those programs forward, right? So you have mental health deputy, a public health deputy, and then we have a financial and operational. And all of those bring it forward, and then you have one person who can see on top of all that. They can say, well, I need you to collaborate on this. You're both working on the same thing. I need you to collaborate on this or this. There's also that expectation now that those deputies will collaborate first, that we will look for savings within our department first, that we will try to get service providers together if that's what's needed. So rather than those 2 very separate things, you have one, and then from there it goes down. And so partly this is meant to, I don't want you to be able to see the difference. I don't want you to ever undo this. This is very important. Like, this should look like one thing. We are one thing. We are no longer siloed from each other. Those people now sit much closer than they used to. It used to be they didn't talk, now they're a phone call or an office away, right? We are blended, we are integrated. And not just in name only, not just administratively only. I'll keep going. So once we reset our structure, we were able to then move forward. And this is looking smaller on the screen than I'd hoped, so you might have to read it in your packets. I apologize. But I'm just going to highlight a few things from this. And I wanted to start with the improved client service, because that's the most important. That is why we did it. That's the most important thing. This past fall, we opened a mental health clinic, a fairly large mental health clinic at the Brown Road location. So now if you walk into Brown Road, there is no service we can't provide you from across both locations, which is felt like a monumental feat. To get OMH and DOH to agree to that, to agree that they could even be in the same lobby together when we're all supposed to be working toward integration anyway, we had a lot of silly conversations. It felt like a monumental 2-year-long feat, but it's done and clients are now being seen. So that's been one of our biggest successes. We've also created an internal referral system, which has been very important because our staff didn't know how to engage their clients into the other programs. And so we needed them to have an easy way to do that. And so we created our own system with the help of IT, where you just say this person needs all these services. Check, 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 hit send. All of them get emails that there's somebody on the way to you, right? And so we wanted it easy for staff, but we also wanted it easy for whoever's receiving it. That's been very effective. I'll show you a diagram or a chart on how that's been going later. But that's been really effective. But we had to literally educate staff on each other, right? If everyone thinks they know what WIC does, you don't know what WIC does until you go visit WIC and go down their hallway and see what they really do. How many staff do they have? How many people do they see? It turns out we probably see many of the same people, right? You don't know what mental health does unless you go see them. And so we've been sending staff to each other's staff meetings. We've been having them work together, pair up, and just learn about each other. And what that has meant is I now trust your services, right? I want to send someone to your services. I know you, I'm confident in you, I know what your services are, I'm confident in those, and I will bring my client to you. And that would have never happened in 2019, never. There's such a beautiful change that we are now experiencing. And I've asked staff, so now I get almost 20 emails a week just telling me this is the great thing that happened when me and this other staff member worked together. The client got better service, or they got any service. They might not have gotten any without us working together. And so I now have this big running list that we share with each other to show those who are maybe more skeptical, this is working. This is good. Look at what it's doing for your client. And when you tie it to the client, staff members tend to follow. They're willing to take a risk and say, I'll do it. I'll be the first one that says I'll go out to that school, or I'll be the first one that says, I'll go see WIC. All of a sudden you get that collaboration piece. But the system is always trying to suck them back in. This has got to be very intentional. If we don't keep on it, the system wants them to go back to these are two different things and we don't talk to each other. So it's been very important to keep our energy up there. And I've talked long enough on that one, so I'll just keep going. We've also paired them up on collaboration projects, and I'm only highlighting this one because this is where we view it as sort of the grassroots. So no one from administration is telling them what to do. We're just pairing up staff, saying learn about each other, and you can pick what you want to work on. What would be the thing that would help your clients the most? Learn enough about each other, pick a project to do together, and then do it. And that's been more successful than most because they know the work, right? They don't need me to try to figure it out for them. They know the work, they talk to each other, and they pick a collaboration project, and we're gonna have reports back in July about how those all have gone. But they've been successful so far. I'm excited about those if you can't tell. Like that is where some of the real work has happened. I'll skip over the leadership part. We've talked enough about that. Shared services and operations, all administrative functions are not done by one team. And I can't overemphasize how hard that is to be done by one team. To know both states' agencies and all of the reporting functions and agendas and budgets and needs, but we now have a team that does that, and we didn't add to that team to make that happen, right? So we just took administrative staff from both places. We now have a billing team that bills both for immunizations and mental health. That never happened before, right? So the same team is able to bill for all, which is why we've been able to hire people. We have efficiencies now. We've found these efficiencies within our own staff, and they're doing a great job at it. You can see the rest of those things there. I'll just keep going. Those staffing and budget considerations, many of those are the job descriptions that we needed and we rewrote and found a way to pay for. And you'll see a list on there, things like data analysts. We brought on additional support staff and we brought on some HR support. We have a planner now who helps me with this presentation. She does excellent work. She does all of our strategic planning stuff. So those were the positions we were able to bring on without asking for any more county dollars. Quality assurance and improvement, we did not have a unit prior to integration for that, and now we do. Education and outreach, it was very difficult to get the word out about mental health before this but public health had those staff. And now we're able to share those staff and they send out information to the community about both whenever we have something coming up. And this one's big, this last one about planning. Both departments are always responsible for these huge plans, these huge community focused plans. And they were never really aligned prior to integration. Now those staff that work on those plans work together, understand each other's plans well enough to add items to both so that we're all working on the same things, or at least there is some overlap. That way we're all going forward together. The next one, strategic plan. Our strategic plan is joint, so we are all working on the same things at the same time. And I know I'm going longer than I probably should, so I'm just gonna keep going here. I wanted to highlight some of the most recent successes here. And this is your left-hand side, at least as far as I can see it, is the Brown Road Clinic. Just opened in November. You can see the hours there. Please feel free to tell people that it's there. One of the best things that this allowed us was client choice. If it's difficult for you to get downtown to Green Street for mental health services, Brown Road is a great alternative. Yep. It's quieter, there's parking. If you're a family and you got 6 kids and you want to bring them into that lobby, it's much easier than trying to get to Green Street. And so they have choice, but also once you're there, obviously we can provide more services to you. We have capacity for 500 clients to go there. We just started in November. We're not going to be at 500 yet, but that first one is showing sort of the steady upward growth of services. So just from March to April, we're going up by 100 at a time. And we expect to see that continue. The one below it is sort of how many unique individuals are going there. And again, more and more people, as word has gotten out, are going there. And we expect to see that climb to the point where hopefully we max out. Hopefully we're seeing 400 to 500 clients there. The bottom right is your internal referrals, which is what I was talking about before. Prior to working on all this collaboration work, you can see the beginning of last year, there were almost no referrals going from program to program within whole health. Since that clinic has opened and since we've been really intentional about collaboration, you can see how many now each month are being referred from one program to another. And that's been really important. That's where both our staff and clients get to see the purpose for this. This is really where word gets out, hey, I'm getting better service because of the referrals that are being made. Again, that's that great referral system that some of my staff created, and I want to give them kudos for that. But we'll keep going. This is meant to be ongoing. So this year, we're really reflecting back on integration, and we're highlighting a bunch of points along the way. And what we're giving you is a public link. We're going to be updating it all year long, and we're giving staff a chance as well to put sort of the more monumental things that they saw, which we'll be doing in June in our all-staff meeting, where what was important to you? What was it that made integration finally a reality for you? And we're going to fill this road up, and we want to see what we've learned so far so that it can inform where we're going. Because we are not there yet. We have done a lot, and I'm very proud of everything that we've done, but we are certainly not to the end of integration. There's still improvement to be had. There's still work to be done. And this is the one that gets me up in the morning. This is meant to show you what it might look like if a family or an individual comes into our doors. And all those puzzle pieces used to be completely separate. I always think of them as being like on the floor. They don't touch each other. They're lost or something, that you can't access more than one at a time. And for this particular family, maybe they need an immunization, mental health, and pros. It's up to us to know which ones and put those pieces around them going forward. And not just hope they integrate, not just hope they engage in services, but surround them with good services. Also, you can see the three sort of areas of deputies there, and you can see how they mix. I wanted you to be able to see that there's the public health side, the mental health side, and the sort of support side, and how they all have to work together. Now, flow-wise, if the next family comes in and they need different services, we should put those pieces in differently again, right? What do they need? But this is what we're all hoping to see in the future. And we have done a lot to get there, and it's looking better all the time. But in the future, I hope that this is so obvious that everyone comes to us for these services. And the last thing I'll say is, this model, I think over time, gets you outcomes that lead to less crisis, right? You get better outcomes more quickly, and you avert the need to go to the ER, or you avert the need for a family to fall apart in some way, because we were there to put these pieces around them at the right time, the right place, with the right staff. And integration has given us that opportunity. So that's all I've got for you. Thank you for your time.
Well, thank you for coming and sharing, Jeremy. Being somebody that's worked in government for 26 years, I often scratch my head and just wonder why we're so stuck to doing things the same way, because we always did it that way. So it excites me when folks kind of take a chance and look at doing things different. And I could hear the passion in your voice as you were going through the presentation and the excitement. And when you start talking about integrating and breaking down barriers and removing silos and trying to figure out how to take a family, a person, and look at them holistically, and how do we deal with all the things rather than be sent here, sent there, go over there. And as a person in crisis and struggling, the more places you have to go, the more places you're sent, the more appointments you have to make, the less people talk to each other. It becomes absolutely frustrating. And a lot of times people don't access the services because they just feel like they can't get anywhere. So this is extremely exciting and very well put together, and thank you. I'm excited to see how this continues to work for people. I used to utilize the benefits when you get the milk and the cheese and WIC. And there was a point in time where I lived on the north side housing community, and they had an office set up in the community room, and you could go over there for appointments. And I thought it was the coolest thing, because getting up to this is when y'all were located by the hospital, it was really difficult. So people coming so it just is nice to see a department keep trying to figure out how to I say this a lot, create better outcomes for people. So thank you and your team very much. This is exciting.
Yeah, thanks.
Shauna, Randy, Shauna?
Yeah, I agree 100% with Travis. You hit a grand slam today. You did a wonderful presentation, and the passion was just so obvious in the way you're presenting, and you should be really proud of yourself.
Thank you. I'm really proud of my team.
That's what it shows. It's obvious. I would love it if Rob or Taylor might be able to clip your presentation and provide it for the Community Services Mental Health Board and the Board of Health, because I think like that 10 minutes that you did your presentation shows exactly what's going on in your department, and I would love for them to understand, since they were all part of the conversation 6 years ago.
Sure.
And then I think the only other thing is, speaking from someone who also has been part of the WIC program, the MOMS program, early intervention. I have 3 kids. At one point in my life, we've been through those offices. The convenience of, bringing along 3 little kids, seeing the lactation consultant, going up to early intervention, like there's just so much there. And you're right, making it easy for people. I love the fact, and I have had constituents talk to me about the mental health services on Brown Road, because I live in the Northeast area, and people don't always want to come downtown and find parking, and so it's really been very helpful to have those services where we live. Thank you.
Randy?
Yeah, thank you for the presentation. I learn a lot every time I come to one of these meetings. And congratulations to the whole group. And I like the name Whole Health, by the way. You mentioned quality assurance, and there's 4 FTEs there. What do they do?
Okay, so we went from having almost no data-informed decisions to, one of them is a quality data analyst who processes our data at an extremely high level. And we use the information every week to make decisions. So we know what we want to know, and it's hard to find the information, and so one of them is doing that. One of them is the leader of that group, so that's the person with the vision to make sure that all of these things occur. One of them is reviewing clinical charts, right? So we're going to get audited by OMH every 3 years, and we want to make sure when the auditors get here, we've already followed all the rules and that our charts look good. And then one is records management. So we get many, many, many requests for records from us to go to someone else, whether it's courts or another provider. And so that that's just a full-time job for them. And insurance companies, whoever needs information about our services.
Thank you. You also mentioned unique clients up at Brown Road. What is the definition of a unique client?
Yeah, so the service data I showed you was like 250 services. That's made up of 120 people. Right, so I wanted you to be able to see not just we're providing a lot of services all to the same group, but that there's a growing number of individuals coming, and so that's the difference. We use that number to make sure that we understand utilization of services.
So they're unique to Tompkins County Whole Health?
Yes, at least they're unique to Brown Road, right? That's what we were looking for. How many people are physically coming to the building?
Okay, understand that. And lastly, and I've shared this with courses as well, and you mentioned, I saw on your slide that you have somebody in charge of facilities at Brown Road. Is that correct? Or, first of all, it's very clean there. I'm very, very impressed with all the cleaners we have in all our buildings.
Yeah, shout
all
out
the
to
buildings
the
that go in, they're clean. I mean, the bathrooms are clean, so congratulations to our custodians, because that's not easy work. But the outside of that building doesn't look very great. Mm-hmm. And when you walk in there, there's a metal post with a light. It's all rusty and it's bent over. Mm-hmm. And the lawn wasn't mowed. When you want people to come into our facilities, they've got to look presentable. And so I don't know what the solution to that is, but maybe it's a matter of a team or some focus where hey, people do an analysis or assessment of their facilities to share with facilities who they're overburdened with things to do, obviously. And that's not just that building. I'm not picking on that building, but we just need to do a better job with that, and I will support whatever needs to happen with that.
Okay. When I label facilities there, it is what we want done with the facility, like building out the Brown Road Clinic, right? Somebody had to plan it, organize it. work with our facilities team. So I don't have any staff who are mowing the lawn, right?
Okay.
And I do know that they're overworked, and it's been raining nonstop, so it's been hard to get in there.
Yep.
And we do have a creek that pretty much runs through the lawn.
Yeah, I saw that.
But so when I'm talking about facilities, it's like for 150 people, it's a quarter of a job just to deal with facilities work orders, right? Just to keep up with it.
How bad?
Yeah.
Right. Thank you.
Any other questions? All right. Jeremy, thank you so much. This is a great example of doing things different. I really appreciate it. Really exciting. Thank you. All right, we are going to move to other departmental updates. We have Kate from the County Youth Bureau, Youth Services. You're on mute, Kate.
Sorry, you think I would know how to do that. Can I share my screen? Is that cool?
You got something going on over there. You got a buzz or something happening.
May I share my screen?
Is that coming from there? Is that outside? There's a dump truck or something happening right now. Okay. There we go.
Can you guys hear me?
Kind of.
Can I share my screen?
Sure.
Okay, all right. Hold on one second. I just want to take an opportunity to highlight, as you know, homelessness is a huge issue in Tompkins County for youth under the age of 18 and those 18 to 25, and also for adults. But in recent talks with county administration and in some conversations that we've been having with some of our community partners, we were asked to create a report that focused on 18 to 25-year-old individuals, young adults without children. And so this has recently been completed. Travis, I sent this to you in an email so that you can share it. This is a report that Rick Albert from our department put together. He's our runaway and homeless youth coordinator. And the idea was that we would create a list of recommendations that would be submitted for your review to just consider as you're looking at plans to develop the shelter and think about layouts and how to address particularly the needs of the population from 18 to 25 without children. Because if we know that there are times if you can do interventions, if you can wrap around services and do things differently, you can actually decrease the statistical probability that those individuals will remain homeless and continue to use adult services as they age over time. And so one of the greatest things that we have heard from people is that even if we get recommendations, there's so many different things that play into that. OCFS stops at age 18. OTDA can have best practices, and there can be different needs. And so it's all over the place, and it's really hard to sort of streamline and figure out what is best practice and where's the data, where's the information that is needed to back those up. And so I'm really proud of this. It's done really well. Rick has created an overview and a one-pager for you all that gives 6 recommendations that are based on local conversations, data, best practice. He's spoken with other counties. So you've got the one-pager here that gives you 6 recommendations of things to consider for that particular age group. But then we went ahead and did just a very small report for you guys that gives you an executive summary. And there are clickable links within here that take you to the links on positive youth development, trauma-informed care, housing and urban development, HUD, the HUD count, the PIP counts. He's done a really great job with some statistics here. National Network for Youth. So, and as I said, this has gone out to Travis so he can share it, but just wanted to bring this to your attention to let you know it's there and everything that you need to kind of understand where we got the information from, where it was pulled. All the sources have been listed, and the things that were not necessarily sources that we cited or quoted from, or our theories or background information for that have been included in the report. So it's all in one place for you and really accessible. And these are just some of the folks that participated in some of the conversations we've been having. And again, this is for ages 18 to 25. We know that we, at this point, do not have a homeless shelter, and there are still challenges for 18 youth under the age of 18 that we are continuing to work on. We're continuing to update our website to hopefully be more user-friendly and have places where folks who provide services can list things that they need or things that are available so that we can connect those who are unhoused or at the risk of being unhoused with some services, with some resources that they might need. So I was just really proud of the work. It came out really great, and I just wanted to highlight it, let you know it was there, and take any questions if you have any.
Thank you, Kate. I did share that with Randy and Shauna, and I'll share it with Amanda.
Thank you.
Does anybody have any questions for Kate, or is there anything else you want to update us on, Kate?
That was just something I wanted to highlight, and then in that email also, Travis, I did ask just times over the next 2 or 3 weeks to meet with you to talk about having some sort of youth summit-ish style event here in Tompkins County as well. So we're excited about that.
All right, great. Randy, Sean, questions for Kate? No? Thank you, Kate. And let's be in touch tomorrow or Thursday and set up a time to connect.
Okay, sounds great. Thank you.
All right. We have John from the Human Service Coalition who is standing in for Cindy. John, you got
Good
any
afternoon,
updates
everyone.
for us?
Thank you, Travis. Good afternoon, everyone. Yep, I'm here in place of Cindy. She's in Albany meeting with the New York Council of Nonprofits this afternoon, and so asked me to step in and just provide a couple of updates for you today. First is just an update on the county, city, community agencies funding review process that the Human Services Coalition facilitates to be able to make recommendations to county administration and to the legislature as part of the budget process. Cindy mentioned, I think last month, that HSC's application window was open. Since then, applications closed on May 8th. I do want to thank county administration for their partnership over the last couple of months in helping to get the word out and to help address any nuances or questions that came from some of the applicants. As we expected, given the kind of growing need, that there was a larger pool of applicants this year. Had about 40 organizations that expressed interest to HSC, and we had a total of 31 organizations that applied, which is up about a quarter from last year, including 10 first-time applicants, all of whom we met with in advance to make sure they understood the process, to make sure they understood it was funds, for 2026, not for next week, and to let them know really how the process works and all of the nuances there. So appreciate any of you committee members who referred organizations to us. I know, Randy, I think you sent at least a couple of them over to us. So between now and mid-June, HSC's review committee will be evaluating the applications, meeting with the applicants, talking through and working on preparing those recommendations to the county. We've got about 20 hours of meetings scheduled over the next 3 weeks, plus probably twice that or more in reading and preparing and evaluating outside of the meetings. We've got a dedicated committee this year with expertise in human services and nonprofits, philanthropy, program management, and more. And Cindy wanted me to call out the committee members for all of you. We have 9 dedicated committee members this year, and they are Steph Bailey, who's the System Director of Philanthropy at Cayuga Health, Christine Barksdale, who's a small business owner and a prolific volunteer and board member around the community, Diane Cohen, Executive Director of Finger Lakes Reuse, Katie Compton, whose day job is with Calvary Baptist Church, also an HSC board member, Tierra Labrada, who's on the staff of the Supportive Housing Network of New York, but who lives here in Ithaca, Nicole McPherson from the Cornell Einhorn Center, Linda Matteo, who's formerly with the Park Foundation in Cornell, Emma Recchio, the City of Ithaca's grant administrator and also a HSC board member, and Katie Sims, who's an HSC board member. So they've got their work cut out for them. By the next time this committee meets, I think our recommendations will be in, and we would look forward to sharing those with the county and seeing you in the fall for the budget process. So appreciate all the work that group is doing. Our second update is just to briefly share with you some of the work that HSC's been doing in partnership with the county around transportation. As I'm sure you all hear a lot, transportation is one of those big issues that always seems to be a barrier for lots of folks, and is one that, making some progress on is really important to all of us who are service providers. We've been working with county transportation planning at the Tompkins County Planning and Sustainability to build out what is called the One Call, One Click Center for transportation support. And this is for community members and other service providers to be able to address and provide resources for those transportation-related needs. We've been working really closely with Frank Doldo and Courtney Horner at the county, plus various other partners, including Go Ithaca, transportation providers, and other partners. We've hired 2 new staff members at 211 who will be specializing in transportation needs, though they've been trained as full 211 operators to be able to address any needs that someone has, but they're going to be focusing on transportation. These staff will be providing assistance for community members around their transportation needs, doing trip planning, helping them access services, get access to discount or free TCAP passes, for example, and other resources, but also helping to build the volunteer driver or the volunteer transportation capacity in Tompkins County. We know that funded programs don't have the full capacity to meet all of the need, but in many locations, volunteer transportation is a tool that communities use to be able to fill the gaps. And so as part of this contract with the county, we'll be helping to recruit volunteers, help organizations to work together. We've had a few meetings already just in the last couple of weeks around how organizations might be able to share volunteers or work more closely together to get rides for their clients in a way that works for everybody. And so that's a big piece of the work as well. The One Call, One Click Center will also allow us to expand our local 211 coverage right here in town until 8 p.m. on weekdays to be able to support folks on their commute home if they've got an issue or need some assistance. Some of you may have been there at the kickoff for the Tompkins Transportation Scout app, phone app, mobile app. That's part of this project. And our staff have been doing a lot of outreach, and they're planning much more on an ongoing basis, including attending some of the community justice center hubs, meeting with county departments like Veterans Affairs, Office for the Aging is coming up, and more, visiting libraries, having office hours in urban and rural apartment buildings, and more. So we're really excited to be able to work with the county to be able to increase options for community members who are experiencing those transportation challenges, and particularly to increase our capacity to meet some of those needs at a cost-efficient way through volunteers. And last thing, just a shout out to the County Administrator. Corsa will be presenting on the Tompkins County budget process tomorrow as part of the HSE Forum series. That's 9 o'clock by Zoom. We really appreciate Corsa volunteering to do that. This is typically one of the more popular forum topics for the not-for-profit community to understand what the budget situation outlook is for the county, even though there's lots of uncertainty and questions. And so we appreciate his time in sharing that with the not-for-profit community. That's what I've got. Any questions?
Any questions? Shauna, Randy?
Yeah, thank you, John. Yeah, transportation is such an important issue for marginalized people, rural people, people even just a mile outside of town. So I'm really glad you guys are working on that. How do you, you have your budget, obviously, that you have for 2025. How do you determine what your budget's going to be for 2026, or is that what you just alluded to with speaking to Corsa?
You mean for the community agencies?
Right.
Well, I guess we've got the same guidance that the county departments have, which is essentially that we're going to prepare a budget now and submit that in June, and then as more clarity comes, we may be asked to revise that budget. But I believe what county administration recommended we do is prepare it kind of a flat budget compared to last year, and then it may need to be adjusted.
Thank you. Any other questions? John, thank you for filling in. It's great to see that there were so many applications come in. I really appreciate the hard work that y'all went through to be able to get it online and open it up. I know that wasn't easy, but I think that the community as a whole will really benefit from that. So thank you very much.
Yeah, thank you very much. Appreciate it.
All right, we are going to go to the county administrator's report.
Okay, I don't have a lot here, but okay. I just came out of the call from NISAC regarding the county's this federal budget, which was very interesting, and they shut me down in terms of the things that I wanted to say. So the call is for us to reach out to our representatives to vote no on the current bill not in Senate, at Congress, because basically we are facing losing in excess of $15 billion a year for human services alone. And the estimate shows that there will be about 200,000 people losing their health insurance by the year 2029. So the call from NYSERC members is for the counties to call on their representative to vote no on the bill as at the current form that it is in. So that's what we need to, that's where we are. We don't know where that is going to land. If it could be voted on any time from now before it's referred to the Senate for the Senate processes as well. The goal is if it passes Congress, we need to put the same degree of pressure, hopefully, on the Senate to make sure there's significant changes so that New York State doesn't lose the level of cuts that we are all facing. And it affects all our human services, even including those that are significantly funded by local dollars as well as state. So there is a call for us to make sure there's a push to make significant changes to that. Besides that, the other update I have is that we completed the interview. No, we are in the final stages of the interview process for the whole health commissioner. Our hope is to be able to complete that hopefully by the end of the month. DSS process will begin next week significantly in terms of the face-to-face interview process, and we are hoping that we will complete both of those processes by mid-June, towards the end of June. So that is the considered effort that we are pushing for that. As I indicated at the legislature meeting yesterday, we received five bids for the shelter development project. Currently, I think one of them is not viable, but the other four are really competitive and viable. So we will begin the process of reviewing those bids, and we will discuss with the committee as well in terms of the degree of involvement that you would like to have in part of that review process. We met with OTDA yesterday to review our concept paper that was submitted to our consultant. There is a huge degree of work that we need to do to make the application very competitive. And the biggest portion of that process is to identify the service provider, because the service provider input is significant in the process. So we are setting ourselves a target of being able to get a provider by the end of June so that they can really be involved in the process of crafting an application that will be very competitive, because there's that limited resources. A lot of applications are expected to come in, and we need to be in good shape to be considered. So that is one of the goals that we have set for ourselves, to try and submit a very competitive application in there. So those are the update I have. I don't know if Bridget, you have any other additional update for us? Yep. So that's all our updates.
All right, thank you. We are going to move into executive session in accord with Article 7, Section 105 of the Public Officers Law. Sorry, is there any questions for Corsa? Okay. So we are going to move into executive session in accord with Article 7, Section 105 of the Public Officers Law. Executive session is only appropriate for the discussion of, in this case, F, the medical, financial, credit, or employment history of a particular person or corporation, or matters leading to the appointment, employment, promotion, demotion, discipline, suspension, dismissal, or removal of a particular person or corporation.
You want me to move that?
Oh, yeah. Do we have a mover? Sean? Randy seconds. All in favor? All right. Guess we'll take a few minutes, maybe 5 minutes, 10 minutes? 5?
Thanks, Chairman.
All right.
That was good.